So without further ado, I just want to introduce our speakers. So first up, we're going to have Mauricio Barreto. He is the director of the Center of Data and Knowledge Integration for Health, CIDACS, which is part of Fiocruz, which is very, very important. In fact, one of the world leading organizations for research in public health in the world. And CIDACS is really being founded by Mauricio and directed so far up to great success, and is really a repository, as you will hear very shortly, for very, very important, particular administrative data in Brazil, but have much, much wider significance. But I think what's much more interesting in a sense for us as a mix of people who are interested both in public health, in epidemiology, data linkage, data governance, and ethics is the fact that they have been playing and they continue, and in fact will go on to play an ever more important role in thinking about how do we link different types of data, particularly data of relevance to public health, in a way that is more both scientifically valid and in fact groundbreaking in many ways, but also with a very strong eye to all the issues that are now more prominent than ever on the ground in terms of public health, which are issues to do with social inequality and how we think about the global burden of disease and take advantage of this data in a way that helps us address some of the very, very urgent questions that have come out, especially in the last few years in light of what's happened with the COVID-19 pandemic. I'm not even going to try and summarize the humongous set of awards and recognitions that Mauricio has been very, very, that well-deserved way honored with throughout his career. Certainly, I would say is one of the world-leading epidemiologists in the world, and has been instrumental in pushing forward so many different methodologies in a way also that, for those of you who are philosophers in the room, has been incredibly philosophically rich, and in fact, he's even collaborated with some philosophers in the past. He has published over 600 peer-reviewed papers and had basically, impossible to summarize impact on the way in which we think about public health globally, and certainly in the Brazilian context. He is an honorary professor at the London School of Hygiene and Tropical Medicine, with which he's had a long-standing collaboration. And so with, I can't imagine how many institutions around the world, but I would say Mauricio knows them all, if they are worth their salt at all. And right after his talk, where he's going to introduce us to the work that CIDACS is doing, Betania de Almeida is going to be talking, and she is the second time that she comes to Exeter, in fact, so been honored twice by her presence, but she has the unenviable task in some ways, but also incredibly exciting, to actually head the data governance component at CIDACS, with all the incredible challenges that this involves, and growing and growing into the future. She will be talking to us about that, and she comes from a background of sociological research, but of course can do also looking at the social determinants of health. And with this, I'll leave the floor to Mauricio, and again, thank you very, very much for visiting us this week.
Okay. Thank you very much, Sabina, for the invitation. It's a great honor to be here in Exeter. Sabina was visiting us a few years ago in Salvador. Then is a continuation of this talking. I'm a doctor and an epidemiologist, but I have a lot of try to have under my capacity and limitation talk with philosophers to discuss our dilemmas, problems, and challenges. And what I'm going to talk here today, to give you a general broad view of the center, and that is using data from linked data, from big Brazilian databases, and then my idea is to go through the questions or the how this was set up, and give you some examples of research that we are doing with this data. First, I'd like to say I'm from Salvador. I don't know if people know about. Salvador is a city in the northeast of Brazil. Is a 3 million size. The population 3 million people. I have a huge bay. Around Salvador. It's a very beautiful city. Then who want to visit is very welcome. It's a very unequal city. It's like other cities in Brazil, but very diversified and historical. Have historical elements and very syncretic. In a sense, it's a very black city. A lot of the African flow to slavery flow to Brazil was for a long time based in Salvador. But I like to put to you some challenges, yeah, that move us to do recession, to set up the CIDACS, yeah. You have increased social inequalities in the world, you know, all the people who work in public health, in social epidemiology, know well about that, yeah, the impact that this growing inequality have. You have climate change, you have a complex multifactorial disease, you have different health challenges, aging, NCDs and the others. You have new risk and new epidemics. Now you saw we are increasing, in fact, of the COVID-19 pandemic, and other pandemics are waiting for us in the near future, possible. Yeah, and you have a relatively limited, inefficient research and development model. Yeah, despite that, our glorification of the science, of the health science, that have been very important in some aspect, but you have a lot of limitation that need us to think about. Yeah, there is a lot of epistemological question in our science. Yeah, I'm not going to develop on that, but there is a lot of dilemmas. Yeah, in health science that in some moments this need, or this have been some way discussed. Part of this by philosophers or that thinking about what's going on in the limitation of our science. One area is the data area. Now with big data, now for all the time you use data, but now you are using large set of data. And one question, that is more recent question, on data-driven versus hypothesis-driven science. I think these are also one question that come all the time for us. Yeah, the data in health have grown a lot. Yeah, it continue to grow. Yeah, as you know, every one of us have different contact with the health system. Is the system in terms of where the people have more contact. Yeah, education. You are here in an educational structure. Now, in general, you have education contact during your youth. Yeah. And only the professors and the workers that stay all the time, but the great part of the population have it during the youth and no more after that. But in the health system, you have a lot of contact at the birth period, have a bit less contact in the youth and the adulthood, the young adults, and then you start to have usually frequent contacts during the later adults and during the aging process. They generate each time more amounts and amounts of data. In a country like here that you have a national health system, this is a huge amount of data that potentially can be anyway integrated and used for good, yeah, in terms of producing knowledge from this data. This, I think, is one of the big challenges, yeah, nowadays. Brazil, we have a national health system, not so organized here. Yeah, you are in the midway, but there is possibilities, yeah, to integrate part of the data that's produced in the country. And in CIDACS, you use it, part of this situation to develop CIDACS. The idea of integrated data is old, yeah. In some science, like cartography and the other science, people have been integrating data, yeah, layers of data. Something similar have been developing for time in the health area, yeah. That these data that in general are in different silos, yeah, traditionally have been different silos, could be in some way integrated, yeah, in a process that form information commons, yeah, where all this data can be integrated. But this generates a lot of dilemmas, a lot of problems, a lot of challenges, yeah. That the first question that I'd like to put is that the data that you're talking about is a data that's not produced for research. You have a part of the data that, like a trial, for example, someone that collect the data for our survey, they collect the data specifically for research, yeah. But part of the data that's produced, or the data that's produced normally in the health system, they are not data for research. Nah? Then you try, you use this data for research, but the data was not originally produced for research. I think there's a huge difference in these two types of data. In the first one, in my view, the major difference is the contract that is signed to use this data. In the normal research, the subject of research sign a contract. The informed consent is a contract with the researcher and give the data and create condition, define the condition that the data is used. In the use of routine data, there is no this contract. This contract is established by ethical committee, by laws, and by all the type of rules, that created the relationship of the research with the data. To transform this data in knowledge is a challenge for us. A lot of people try to do that. Is the process of transformation of data that is routinely collected, and prepare, organize the data to produce knowledge. This is the big issue of data centers around the world that have this objective, to get and to, in some way, to put together this data, to organize, put together, and transforming in a tool to answer scientific question, evaluative question, etc. There are many challenges to that, that involve different dimensions of the process, involving different disciplines of knowledge, that people have called data science or population data science. There is now a more focused area of population data science, but I can say, in some way, a lot of different sciences have worked with data for historically, and in some way connected with this process. I'm an epidemiologist, and for a long time you have been working with data, and then, but there is new challenge, the fragmentation of the data, availability of the data, handling of the data, management, and one big question is the privacy. This is a modern problem, that to protect the data is a big question in society. How to create barriers, if in the case the data is used, how create barriers sufficient to protect the privacy and the identification of the individuals. This is a major question that needs to be all the time discussed, and also involving different disciplines, ethics, computing, the people developing strategy to help to protect privacy, and the others action to protect privacy, because it's not a simple question, because when you link data, you increase the dimensionality of data. Sorry, my English sometimes is difficult to say some words. The dimensionality of the data, then this creates problems of identification, for example. That is a big issue nowadays. Then this the question of privacy is very complex. If you talk with a person, people only think about the anonymization of the data. If you took the identifiers, you solve the problem. It's not so simple, The same instrument that help you to organize and to make it, improve the data and sometimes analyze the data, can also be used to identification. And there is algorithms nowadays that have a huge capacity to identify data. Then this is an important issue. Then I'd like to talk about CIDACS, history of a bit of development of CIDACS. In fact, no one have the plan to organize a data center at the beginning, but the history started some years ago. I'm an epidemiologist, and in the moment of my life, I was very much interested I have been studying relationship between poverty, health inequalities, and the health for a long time. And in some moment, I was interested to change a bit, yeah, and see how if policies, yeah, dedicated to interfere in health determinants were possible or not, yeah, to affect the health. This was a question. My question of my group in some moment of our development, and then Brazil is one of the countries that implement a large program of called conditional cash transfer program. The conditional cash transfer is basically the government pay a small salary, yeah, for families that are poor or very poor. There is a specification, a lot of things, that details, but basically it's a transfer. It's like a person have a salary, yeah, that is defined by the government to help the family to very poor families. And this nowadays implemented in different countries. You see in Asia, in Africa, in South America, it's a very popular program, yeah, to go against poverty. And it start to appear a lot of evidence that as a secondary effect of this, yeah, was the effect on health. And then in some communities, started the interest to investigate in great details. And given the characteristic of Brazil, this could be an interesting place to evaluate. Here are some details of the Bolsa Familia. Yeah, and then years ago, you published a first paper on the impact, but not using individual data, using, if there is an epidemiologist, economist, using aggregated data by municipality. Brazil have years 5,700 municipalities. Then using municipality as a unit of analysis, you can do a lot of analysis. It's what the epidemiologists call ecological analysis, the economists call aggregated data analysis. And then you arrive at a conclusion that really there was an important effect, yeah, in areas where there is a good coverage of the Bolsa Familia program, that is the cash transfer. There was an important reduction in the infant mortality rate. Here was used the infant, in fact, under 5 mortality rate, sorry. And this effect was higher in different, in some cause of death, like undernutrition, diarrhea, and the other important cause of death at that time. Later, my group and the others start to study using the same strategy, the effects in a different others outcome. Here you have example of tuberculosis, yeah, leprosy, yeah, malaria, and all the time you find violence, homicides, and all the time you find the association, yeah, the Bolsa Familia positively related with reduction in important cause of death. Then there is a second moment that you start to think you want to use individual data to do our research. Yeah, and in fact, everyone who is registered to apply for a social policy in Brazil needed to complete a document, a big questionnaire that is called Cadastro Único. And this questionnaire has a lot of information on the individual and the family. And the epidemiologists love questionnaires, and then this questionnaire could be initial information of a cohort. And the access for the data was given. The minister of who cared about the social policy at that time was a very bright woman, and she was very very happy with the finds, yeah, that his program, the program that she was responsible, having previous evidence that affected poverty, but then you add to that it also affects the health of the population. And she was very, very happy with this find, and she was very helpful to discuss the possibility to access to this database, yeah, that at that time, we have more than 100 million people registered, near to more than 20 million families, and more than 100 million people registered. Then a huge database. Then this creates a big dilemma, how to manage the system that this amount of data and guarantee the privacy of the data. And if the data was linked with other databases that exist in the country, like mortality data, hospitalization data, birth data, you can have build different things in different and test different hypotheses. Então, basically, a simple view of the process was the cadastro único linked with different outcomes and with some social protection, like the Bolsa Familia. But later you got data from others, other social protection programs. There is a vision behind this, the work with this to do research based on the integration of massive national database. This request efforts, is not an individual endeavor, need a multidisciplinary approach, and interaction with different disciplines, but it can be innovative in terms of producing knowledge about the population health. There was legal question in Brazil at this time after CIDACS was organized. The parliament started to discuss a protection, a law on treatment and protection of personal data that is a lot inspired in the GDPR, the European GDPR, that was in action at that time, And it was very interesting at this moment that you have an opportunity to interact with the Brazilian parliament, because they were interested to know about the experience of CIDACS, in terms of protection data to research. Then there was an interaction, and this even have some influence in the law, and at least one article in the law is inspired by this interaction among the parliament and CIDACS. Então, then created the legal frame, where as it was inspired in GDPR and following in some way try to follow GDPR rules, was very easily adapted to the new legal framework in Brazil. You work here in this building, is part of this building is used to CIDACS. This is the idea of our data platform, the conceptualization of our data platform, involving different level of organization of the data, a data production level, a data curation level, a data access level. Don't mean that everything is fully developed. We have 5 years working CIDACS. Some areas is more developed, the others not so much, given resources, capacity, and the other things. But with a great level of security, privacy, and ethics as important parts. You start to develop some algorithm for data linkage. You see here some example. On the because our linkage is in-house. Different from others group like UK, for example. The research depends on linkage done by a third party. Now in CIDACS you do in-house. Now you receive the database, is possible to do linkage in-house. Then you develop, you don't have a common number in some of these database. Then computing person know about that, how it's not it's a challenge things, to find a pair, if you don't have a common number. Now you need name, age, place of birth. This document comes with some errors, and then everything needed to be in this processing to find the more possible pair for one database and the person in the other database. Then nowadays you use this, the CIDACS RL, is a scoring based record linkage system that was demonstrated to have high accuracy and scalability and is the one that they use. But you see there is a new development, a group, we associate with a group in São Paulo, is developing one very creative idea, yeah, that is based on some biologists that use a DNA encoded approach. Yeah, they transform, they think as the names and the structure as a DNA structure, transform that and do the linkage. This is fantastic idea, yeah. Not yet scalable, not yet we never have used it yet, but it is an idea in development. Yeah, you created some data flows. Yeah, I'm going up this, the linkage pipelines. Yeah, and the safe system, basically you adapt our safety protection or what the here in Health Data Research UK developed the 5 safes, yeah, because all the process, yeah, there is a lot of guarantee, yeah, to the protection of the data, yeah, in 5 different levels. Part of it is things are described in this paper, yeah, that you have interest in the journal, the International Journal of Population Data Science, that is published by the Swansea group, yeah, that is in the University of Swansea. But what I'd like to start and have really interest in general is the asset that you have, because this data is in CIDACS, but you start to organize this data, and as epidemiologists, yeah, was easy to think in a cohort idea, that really important asset that nowadays have in CIDACS, what you call the 100 million Brazilian cohort, yeah, that is a connection of data from the Cadastro Único as the baseline of the cohort, and a lot of others databases connected, yeah, in this initial database. Então, with this cohort, the cohort method, there is some epidemiology here, we use a lot for research. UK have the normal cohort collected data by the researchers. And in UK, there is at least several cohorts in different parts of UK, collect routinely, the people who collect the data of a group of population over time. Then you doing that using routine data. It's the same conception, departure from Cadastro Único, and assemble data and update that data over time. Then is that idea. And then the cohort that started with 114 million, so far have 131 million people. Then this is growing. I don't know when it will finish, but is growing, reflected the new people who have been registered in the Cadastro Único. Here, the databases that are connected, you have description, there is a lot of different variables in the things that is used for researchers who want to extract or to answer a specific question. Here, some comparison of the structure of the cohort. You see, for example, the age structure of the cohort, how it is from people who apply for social protection. They have a lot of kids. That is different, yeah, a bit from the normal population. Brazil have this the global number of people. The format of the pyramid, demographic pyramid is a bottle. And in the case of the cohort, is a bit different, in particular with young children. Have a lot of young children than expected in the population. Another cohort is a birth cohort, yeah, that is similar to the 100 million, but is based on birth, yeah, using birth data and follow over time, but in a very similar concept, yeah. Then I like to show this this cohort exists in a safe environment, and the researchers that want to use the data, they apply for a project. Yeah, this project is defining the variables. Yeah, you have the metadata of all these cohorts, and it's up to the researcher defining what data he or she needed to be extracted from the main data. And this extraction is done in a process of discussion with the curator. There is a discussion to give the data without putting risk, the privacy of the data. This is a process of the discussion that sometimes the researcher needed to don't have some data that he asked for, because for each data set, there is a risk evaluation in terms of possibility of identification. But even these data sets, they are extracted and they flow for other areas of CIDACS. They don't go out of CIDACS, any data. And the researchers who are using through VPNs, they can do the analysis inside the system, but they can't not download any data. They only are authorized to download the outputs, tables, graphics, and the others output, but not any data that can be individualized. It's completely prohibited. There is a system that controls that, to not make possible the download of the data. But the data can be used outside CIDACS. People here, there is some people in UK that use this data, in Glasgow, in London, that through VPN, and it works very well. The linkage between Brazil and UK is very good. Then there is some small delay, in seconds delay, but it's not visible, or there is no perception of that. And the people can use this without any problem. And some colleagues here have used the data without a major problem. I'm going to show some areas that you have investigate. For example, social determinants of health have been a field that you have interest. Here, for example, 2 studies showing social determinants of leprosy. That is a very it's an important problem in Brazil. And birth weight, for example, two completely different health problems, but it can be investigated or extracted from this database that we have available. A paper that is coming soon in the Lancet Global Health, study ethno-racial racial inequalities and child mortality in Brazil. The Cadastro Único have a very nice data on the composition of social groups in Brazil. And these have huge potential to understand health inequality, like this study that show, for example, how the indigenous people exist yet is a small part of the Brazilian population, the indigenous or original people from Brazil. They live in different parts of the country, and yet a very neglected group here. You see here, for example, the mean mortality in the indigenous, under 5 mortality in the indigenous population is near 2.5, 3 times higher than the normal population. And then I think is a way that only through this data and link this data is possible to visualize a situation like this one. Another area that you are very important for us is the evaluation of the social programs, or the effect of social programs, who work in evaluation, be economists, epidemiologists, know that in general you use cohorts, and you use exposed people, not exposed people. In the case here, a group that receive the cash transfer or not receive the cash transfer. And you can study outcomes in the 2 groups and compare that. But you have a problem that this group are different. It's not a randomized study. this group is different, then you need to use quasi-experimental methods or natural experiment methods, yeah, to correct imperfection or lack of comparability, original comparability among the group. This has been an area where you invest a lot of efforts. You have been working with colleagues from different parts of the world, in particular here from Glasgow. They have a tradition to use or develop natural experiment. They have been very helpful in some of our projects, yeah, to develop this, yeah, and to apply this in our cohort, yeah. And then with this, you can generate a lot of different evaluation, for example, show impact of cash transfer on child mortality. Now, not use ecological data as before, but use individual data. That is a lot more, you are capable to do a lot more detailed analysis than when you use ecological data. But it's interesting that the effect was similar. I'm not going details, yeah, but the effect was similar. Sorry. I'm going, if someone wanted the paper have details, including the analytical approach, yeah, you using propensity score as the basic method, yeah, but one associated with an approach more recently developed of called kernel matching, yeah, and then using this two approach was possible to do better comparability among the data and generated data less imperfected and more comparable to solve the problem of the no comparability among the groups. And you see here, there is a 17% reduction in the group that received Bolsa Familia compared with the one that do not receive. Then showing the really important effect of the Bolsa Familia on the reduction of infant mortality. I'm going now, it's possible, I use now data, the individual data, you can see things that the ecological analysis was not possible. For example, children living in the poorest municipality, the effect of the intervention is higher. There is a contextual effect that this has been studied a lot in health. In particular, geographers have studied the question of the contextual effect on health. And you can observe here, poor municipality, the effect of the poverty reduction action of the cash transfer is higher. The impact is higher among Black mothers, that's the poor group. Preterm children that in general have a high mortality, they are have great benefit, yeah, of the program. Here I study on effect on suicide. Suicide is a mental problem, yeah, that is reflect a complex decision of an individual, but it's related with a lot of contextual, environmental, contextual condition, and poverty is one of these conditions that favor the decision to kill himself or herself. And you see, it's a very complex question that have a lot of discussion about suicide, but you see that the effect of Bolsa Familia suicide is yet higher than on infant mortality. You see here reduction in the order of 50% reduction, really equal or similar to a vaccine effect in terms of the magnitude of the reduction in the population that receive. There are a small reduction in poverty have a huge impact in outcome like suicide. Here is other use. Yeah, my personal interest is a lot on epidemic, on the impact of social program, but there is a lot of people working CIDACS with others' interests and the other things. Yeah. Then a new interest was coming. For example, this study evaluated the impact of cesarean on the mortality. I was talking with Sabina this morning. Yeah, use mortality. Cesarean is very common in Brazil. Brazil, 60% of the deliveries is through cesarean. That's very high. It's well known worldwide that Brazil is one of the countries with a high level of cesarean. And you see here that when you classify cesarean, this guy, Robinson, he developed a way to classify the cesarean if the cesarean is medically indicated or not medically indicated. In this study was, I think, the first one to show very clearly that when the cesarean is well medically indicated, it's protective for the child. When it's not medically indicated, it is a risk for the child. Then it's a very interesting find, that is only possible when you have this amount of data. It's a find that is impossible, in normal cohorts, with 10,000, 50,000 people. You not have numbers, to do analysis like this one. Is only possible if you aggregate a great amount of data. Some others analysis, for example, this study on Zika, a lot of study on Zika. You have Zika was a virus that before COVID, you have an epidemic in Brazil and the other Latin America countries, that is an infection during pregnancy that causes a huge effect on the child, death or severe neurological lesions, and they have been studying for a long time, and you have an area of research on Zika, and you have generated very interesting data, on the following this population that's exposed to Zika. Through the register of the Ministry of Health, you have practically everyone who ever pregnant women that was infected with Zika in the country, then give a relatively high numbers of cases, of infection. Then you could estimate, a lot of different parameters, related to Zika. Here is some people here interested in artificial intelligence. You don't have a strong area of artificial intelligence. You have few people that are interested, and you have applied for some problems, like this one that is a tool for diagnosis of Zika. Now you had a problem during our research that was classified the cases, and this group developed a diagnostic tool, and validated this diagnostic tool, to classify the so-called congenital Zika syndrome. You use the data in other purpose, to like development of a deprivation index, you created the Brazilian deprivation index, there was no national based in census tract, Brazil have near 400,000 census tract, and then you created with colleagues from Scotland that have a long tradition to develop the deprivation index. We created this Brazilian deprivation index. In the pandemic, you have a lot of active action and people working in modeling. In the pandemic was a contribution to understand and to evaluate the measures, the social distancing and the other measure that was applied. A framework try to optimize the public health policy when developed, Then there was some interesting development in terms of modeling, going beyond the simple development of the descriptive models. Another activities using the Brazilian data was to evaluate the effectiveness of the vaccines. Vaccines is the COVID vaccine had a complex problem. There was different vaccine. There was different. The effect was different. The efficacy was different, and also the period of waning of the effect was different among vaccine. Then they create the need to have effectiveness study. Effectiveness study are a study that is done post the application of the vaccine in the population, not random studies as the original trials that define the efficacy, you can do effectiveness study. But for this, you need good data. Then using data from Brazil was possible to assemble and to link this data and to do fantastic effectiveness studies. Yes, some of them with our colleagues in Scotland. This was very important because Scotland have a very good tradition to have very good data in health. Then compare the Brazilian data with the Scottish data was an opportunity to show that also then the Brazilian data in some way was as good or at least similar in terms of quality of the data from Scotland. Also to test what's so-called a federated analysis, because health data cannot flow very easily from one country or the other. Then what people does is to develop analysis algorithms, standardize the data, and develop algorithms that is apply the data in different places, and put together the analysis, and the interpretation analysis done together. But the data is kept in different places, and the analysis that is similar, the data is similar, the analysis is similar, and the interpretation is done after you have the two analyses altogether. Or you have some other development, include a platform on analytical models, because one of the problems that the people had who work in this model is the acceptance and interpretation of the models. And then a group of young mathematicians and the biologists developed this platform in an effort, to try to put to the public more clarification of the meaning of the process of modeling during the epidemic. Here, a photo is a lot of young people working in CIDACS, a lot of docs and postdocs, that really is the great part of the inspiration and the capacity and the creativity come from them. I'm the messenger here, because it's these people who really are terrible creative and innovative to propose new strategies. You have a plan of expansion to include new data, for example, environmental data. You have activity with your colleagues from Scotland. You create a National Institute of Health Research, Global Health Research Unit on social and environmental determinants of health inequalities, that you plan, you are in collaboration with colleagues from Ecuador. And only to finish, I know that my time is over. I'd like to say that there is a lot of discussion about that, there is here philosophers and the other scientists, that this model to do research, it's not a competitive model with the other way, but without doubt, there is great potential to integrate more the practice and the research. This is a big dilemma in the health area, that the research is a lot separate from the practice, and this model to do the research uses the data have great potential to transform that. Okay, thank you very much.
Hello, everyone. Thank you, Sabina, for inviting us to be here. It's a pleasure to talk about our work. Thank you very much indeed. Mauricio gave an overview about CIDACS, and I'm going to talk about our initial steps towards engaged data stakeholders in Brazil, consider CIDACS work. The talks that I would like to share with you is about our initiatives on open science and also our initiatives aimed to understanding public attitudes on data sharing linkage, as well as increasing stakeholders' involvement and engagement at CIDACS. This was a project that intended to build a cohort to follow child affected by Zika, microcephaly by Zika and other consequences. Among initiatives, we have an access related to open science. In 2017, we mapped some infrastructures and open data initiatives in 8 countries. In 2018, we decided to understand the Brazilian legal framework on data sharing, open, and also access related to data for health research purposes. And we also took part of the Fiocruz policy on management and sharing and open data for research, the principles and guidelines. In 2020 and 2021, we conducted an exploratory study to understand different viewpoints on the use of data containing personal identifiable information, focusing on administrative data sharing and linkage for research purposes and evaluating public policies in Brazil. It was an exploratory study because it's a new topic in Brazil, the idea of use personal data, special linkage and sharing. And we'd like to understand the people experience on that. It was a qualitative study based on semi-structured interviews. We expanded our data subjects, our participants, to include researchers who work with minority groups and education, as well as data and social science. In the beginning, we intended just to interview researchers who worked in the health area. And our participants included patients and beneficiaries of social welfare programs, and researchers work in different areas, computer science and social science, and heritage and history, and managers with experience in public policy and as well as health and social protection policies. It's important to say that we'd like to know the perspectives of the people that CIDACS use the data for conduct studies, because as Mauricio mentioned, we use the social and health data. So we'd like to know more about what people think about the usage of personal data. In the CAD Único, the Unified Registry, we have a specific population with different origins and also related to the traditional communities, indigenous peoples, groups in rural areas, in disadvantaged situations that we'd like to expand our work on. So that's why we intended and expanded our study sample. And after performing the content analysis, the social categories most prominent was related to documents and citizenships, privacy, consent, and ethics, risks versus benefits, transparency, trust, and data governance. In general, we found that patients and beneficiaries of social welfare programs, when questioned about their data, infer direct association with the identification documents. It's very important to understand in Brazil the relationship between their rights as a citizen and also the documents that they have, because the civil registers are spread in different databases. And the process of personal data by governments raises more fears than actions taken by large technology companies. And the same apparatus that can grant access to welfare services can also generate distrust, fear, and insecurity on the part of data subjects. Individuals and social groups want to receive feedback on research involved with them, also in their communities. This is extraction of an interview of a mother of a child with microcephaly due to Zika virus. And she's a member of a group that frequently, I don't know, that take part of different studies. And she said that many times there are a lack of return about the results of the research for individuals as well for the groups. The involvement and participation of a group in research design topics and studies, as well as data analysis, also will be relevant for researchers. And the importance of opening a dialogue among different stakeholders were also mentioned. And this is an instruction of our health research interview. And she talks about the necessity to consult the leaders of the groups to open the dialogue, especially when we work with secondary data. And regarding risks versus benefits, individuals and groups possess agency with regard to decisions, if not absolute, in certain times in circumstances, they are constantly balancing risks and benefits with regard to exposing and sharing their data. This is a patient who has Hun's disease and talking about the right to be, that the family don't know about their condition, but also, which is also a public health problem, because we need to contain the spread of disease inside the families. So the public policy managers recognize risks and benefits weight more heavily depending on the individual socioeconomic context, which is permeated by intersectionality. And sometimes public policy managers mention that they feel like they were a kind of data custodians, especially regarding the most vulnerable populations. Researchers recognize the need for data access to promote knowledge generation and appropriate public policies. On the other hand, exposing data can put certain communities at risks, even more in the case of territorial disputes in Brazil. This was a researcher that works in history and heritage. As I mentioned before, we have some traditional community groups in the Unified Registry Databases, CAD-Único. And also problems arising from poorly designed data collections procedures that impacts people's lives, as well as the quality of the data collected, were mentioned by the public policy managers. And challenges related to infrastructure interoperability among databases, lack of standards and standardized requirements, transparency and data access were mentioned. This is an extraction of an interview of a public policy manager. She mentioned the problems arising from the lack of financial incentives to have a good database, which will require investments that some governments are not interested in. And she said that she depends on good databases with quality. And she also mentioned the necessity of linkage among databases, because the citizens are not compartmentalized in boxes. Sorry about that. And researchers considered also data, as you know much better than us, in an epistemological context. This is a extract for interview of a data science researcher that he mentioned the necessity to work with the epidemiologists to modeling the problems, but he needs inputs from the epidemiologists. So regarding data subjects, the majority highlighted the fear of losing rights and benefits because of data misuse. This is also another quote. This study content helped us to do a kind of initiative called Your Data Tells Stories and Make History. We used our social media content posted on a weekly basis to call public attention on the importance of data in our lives. We provided some definitions, concepts, usage scenarios, and reflections on ethical and legal aspects on data. We try to help explain the relevance of usage of administrative data for research and public policy purposes. This, if you want to know more about this study, there is a full report in Portuguese, but also a summary in Portuguese, Spanish, and English in our website. And we will start a new project called Long-Term Consequences of Zika virus infections during pregnancy for school-aged children and their families in Brazil. This project aims to accompany neurological development and learning needs of school-aged children with prenatal Zika virus condition exposure, and as well as to evaluate the social and health impacts on their families. Among research questions, there is one that intends to know how can we more effectively engage affected community in the context of public health emergencies. This study will start this year, and I'm part of this work package. And we try to answer some questions, including how can mothers of children with congenital Zika syndrome can be effectively included in formulated research priorities, and in the co-implementation and dissemination of research, what can be done to ensure that research approaches are considered appropriated and useful to mothers of children with congenital Zika syndrome? Will it be possible to implement participatory dissemination activities with mothers of children with congenital Zika syndrome? And are there perceived benefits or harm on this approach? What are the key concerns of affected community regarding data use and reuse in case of public health emergencies, considering Zika virus as a case study? As Mauricio mentioned, it was a public health emergency, localized in Brazil, in the northeast of Brazil. This study will use different data sources, including CIDACS. And as you can see, the work package 4 is transversal to all the projects, and we would like to engage affected family in scientific responses to public health emergencies. And there's also a new project which will last 5 years called Social and Environmental Determinants of Health Inequalities. We have Brazil, Ecuador, and the UK as partners. So we have South-South collaborations, North-South collaborations. CIDACS will help Ecuador to build a data infrastructure there. And we intend to evaluate the impact of several social, environmental, and health system policies on health and health inequalities in Brazil and Ecuador. As you can see, you have different work packages and pillars. I will be responsible at CIDACS with this pillar 1, data discovery, linkage, and preparation, and also be involved in the pillar 4 related to engagement, involvement, and communication. CIDACS is part of a new, I don't know if I can say that, but a new field of science called population data science, which is characterized by 4 aspects, which is need to be valuable, and the public interests would be the core, using data in a positive manner to benefit citizens and society. Data from different sources are integrated and analyzed, and results are analyzed for a populational perspective. And technical infrastructures should be developed, and policies should be elaborated in conformity with regional ethical and legal standards to support scientific research while preserving the privacy of data subjects. This is kind of idea of the different fields related to population data science, which include legal, ethical, and privacy norms, as well as public good and public engagement. So currently we are focusing on acquisition of new databases, including those containing environmental and climate data, improve our data management and data governance practices, building relationship with stakeholders, which are mainly data providers, data users, and data subjects, as well as policymakers and regulators, and providing scientific evidence on populational health to promote social equity. Thank you, obrigada. So we have time to discuss.